Well, hello and welcome to everyone joining us for this X-Talks webinar. Today's talk is entitled Clinical Use of Blood Biomarkers in the Era of Disease-Modifying Treatments for Early Symptomatic Alzheimer's Disease. My name is Corey Stanton, and I'll be your X-Talks host for this event. Today's presentation runs for approximately 60 minutes, and the webinar includes an interactive Q&A session with our speaker. To make the most of this session, feel free to submit questions and comments for our speaker throughout the presentation using the questions chat box, and we'll try to attend to as many as possible. This chat box is located in the control panel on the right-hand side of your screen, and if you require any assistance, please don't hesitate to contact me by sending a message using this very same chat box. Please note that all participants are in listen-only mode and that this event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank C2N Diagnostics, who developed the content for this presentation. C2N Diagnostics specializes in diagnostics for brain health, offering high-resolution mass spectrometry-based biomarker services and products. These aid in clinical decision-making, improving patient care, enhancing clinical trial quality, and supporting healthcare research. C2N's assays have been pivotal in over 100 Alzheimer's disease and neurodegeneration studies globally, including landmark treatment trials. With ongoing collaborations with major pharmaceutical firms, C2N has contributed over 15,000 PreCivity-related biomarker measures to peer-reviewed publications, with even more manuscripts in review. And now, our featured speaker today is Dr. Suzanne Schindler. To introduce Suzanne, as well as take over the moderating duties for this webinar, please welcome C2N's Sheena Arora. Sheena, the floor is yours.
Thank you, Corey, and it's my distinct pleasure to introduce our speaker today. As Corey mentioned, I work at C2N. I'm the Vice President of Neurology, and I can't think of anyone better than Dr. Schindler to talk about clinical biomarkers for Alzheimer's disease. In particular, the field is moving very fast, and Dr. Schindler has been spearheading this research since her MD PhD days in Washington State University, Washington University, and along with her interest in apolipoprotein E biology, she is very active clinically and does biomarker testing and sends and collaborates with Washington University for doing that biomarker testing. She also leads the fluid biomarker core at the Knight's Alzheimer's Disease Research Center, and she has secured an R01 grant to assess novel plasma biomarkers. Dr. Schindler's always reached for the stars. In fact, her first job was at the planetarium in Colorado. So again, please join me in welcoming Suzanne, and I'm thrilled that she is going to lead and charter the way of understanding the fluid biomarkers and what role they play in the early diagnosis of Alzheimer's disease. Thank you, Suzanne.
Thank you so much for that kind introduction, Sheena, and it's wonderful to be with you here today. So as many of you know, in the last 5 years, we've made major progress in understanding Alzheimer's disease. And as of about 9 months ago, we now have a fully FDA-approved treatment for early Alzheimer's disease, and we expect that more treatments are coming. Now that we have these Alzheimer's disease-specific treatment, an accurate diagnosis of Alzheimer's disease is more important than ever before. Fortunately, we have a variety of tests to help us to determine whether a patient's cognitive impairment is likely to be caused by Alzheimer's disease or something else. Today, I'm going to review the workup of dementia and the use of Alzheimer's disease biomarker tests, and I will specifically focus on the unique advantages of using highly accurate blood tests in the clinical diagnosis of dementia. These are my disclosures. Note that I have not received any personal compensation or direct research funding from any diagnostics companies, including C2N Diagnostics. The common question that I'm asked by my patients is, what is the difference between dementia and Alzheimer's disease? So dementia is an umbrella term that refers to a decline in memory and thinking that impairs function in everyday activities. And there are many causes of dementia. Mild cognitive impairment is an umbrella term that refers to impaired memory and thinking that does not affect function in everyday activities. Note that both dementia and MCI refer to having clinical symptoms, and both of these conditions could have many different causes. In contrast, Alzheimer's disease really is a different concept. Alzheimer's disease is a specific brain disease that is defined not by cognitive impairment, but rather by the presence of amyloid plaques and tau tangles in the brain. And we have learned through many studies over the past century that these amyloid plaques start to accumulate in the brain about 10 to 20 years before the onset of AD dementia symptoms. And this means that many cognitively normal older individuals have some level of amyloid pathology. However, once this level of amyloid plaques and tau tangles reaches high levels, individuals are likely to develop cognitive impairment and dementia. Now, as I've noted, there are many causes of MCI and dementia. However, Alzheimer's disease, this pathology, is by far the most common cause of MCI and dementia. However, there are lots of other causes, as I mentioned, and many patients who have this pathology also have co-pathologies that contribute to their clinical symptoms. Now, as you are probably aware, Alzheimer's disease is extremely common in older adults, and it really has a profound and unfortunately devastating impact on many patients, their families, and society as a whole. An estimated 6.7 million Americans aged 65 and older are living with Alzheimer's disease dementia. And Alzheimer's disease is the 5th leading cause of death in Americans aged 65 and older. And this is because patients with Alzheimer's disease inevitably develop complications such as infections that can lead to death. It is expected that the number of Americans with Alzheimer's disease will continue to grow to about 13.8 million people by 2060, barring the development of medical breakthroughs to prevent, slow, or cure Alzheimer's disease. This is all really quite grim and would be very difficult to manage for our society. But fortunately, research has really given us some new reasons for hope. And one of these reasons for hope is the first fully FDA-approved disease-modifying treatment of Alzheimer's disease, lecanemab, which became available last year. And there are many more treatments in the pipeline. So in a recent review by Dr. Jeffrey Cummings and his colleagues, almost 150 different treatments are currently being studied. Some of them are in late stages of clinical trials, so they may become available soon. Relevant to this talk, initiation of Alzheimer's disease specific treatments are likely to require tests to confirm the presence of Alzheimer's disease. So for example, it wouldn't make sense to give an amyloid lowering treatment to a patient unless they were demonstrated to have high amyloid. There is also increasing data suggesting that treatments for Alzheimer's disease are likely to be more effective the earlier they are started, and this gives new urgency to the diagnosis of Alzheimer's disease in patients with early cognitive impairment. So it is more important than ever, now that these treatments are becoming available, that we provide patients with an early and accurate diagnosis of Alzheimer's disease. Now, in our memory clinic at Washington University, patients come to see us with cognitive symptoms that range from very subtle to severe. And a frequent question is whether their cognitive symptoms are caused by Alzheimer's disease brain pathology or something else. And determining the likely cause of cognitive impairment does require a comprehensive evaluation. The clinician talks to a close friend or family member to determine if there are typical symptoms of Alzheimer's disease. Those include an insidious onset of symptoms, slow progression of symptoms, and early impairment of memory in most cases. The medical history, family medication list are scrutinized to look for potential causes of cognitive impairment. The patient undergoes objective cognitive testing to evaluate for impairment, and a neurological examination is performed, specifically looking for signs of stroke or Parkinsonian disorders that can sometimes cause dementia. We perform routine blood work and structural brain imaging to look for issues that can cause cognitive dysfunction. Now, we do this whole workup, but we actually do have specific tests to tell us whether someone has Alzheimer's disease brain pathology. We refer to these as Alzheimer's disease biomarkers, and they have been clinically available for over a decade. However, they have been rarely utilized until recently, probably in less than 5% of patients, and this is for a number of reasons. They have been costly, they have often not been available or offered to patients, and probably the biggest reason is that there was a conclusion that whether the test was positive or negative, it wouldn't alter the diagnosis or management of the patient. And what this has meant is that many patients have not been accurately diagnosed. So even after we do that comprehensive evaluation that I described to you, we know that the diagnosed cause or causes of cognitive impairment is often uncertain and sometimes incorrect. This is especially true when symptoms are very mild or the patient has multiple conditions that can be associated with cognitive dysfunction. One way we know this is a study called the IDEA study that evaluated about 15,000 patients with cognitive impairment of uncertain cause that underwent an amyloid PET scan. After the scan, the diagnosis changed from Alzheimer's disease to an alternative diagnosis in 25% of the patients, and from an alternative diagnosis to Alzheimer's disease in 11% of the patients. What this means is that without Alzheimer's disease biomarker testing, that clinicians are often wrong about whether someone has Alzheimer's disease brain pathology that may be contributing to symptoms. So that's a lot of misdiagnosis. And this has also affected clinical trials. We have learned that in some of the early trials of Alzheimer's disease drugs, which enrolled participants based on clinical criteria only, that about a quarter of the individuals enrolled were later found to have negative Alzheimer's disease biomarkers. And these were people that were carefully vetted and monitored based on clinical criteria of dementia experts. And again, they were misdiagnosed. So what this means is that we really can't diagnose individuals with Alzheimer's disease just based on clinical criteria, that we need biomarker testing to tell us whether someone has Alzheimer's disease as a potential cause of their cognitive symptoms. So when should we do biomarker testing? Well, the answer to that question, when we should do biomarker testing, has changed considerably in the last year due to the new availability of this Alzheimer's disease specific treatment, lecanemab. So in the past, dementia specialists use Alzheimer's disease biomarkers primarily to aid in the diagnosis of patients with atypical or early onset or uncertain dementia. So we did these tests with really weren't sure what was going on with the patient, and we wanted to have some help with our diagnosis. And we did this testing, as I mentioned, in a relatively small proportion of patients who presented to us. And we typically did this late in the diagnostic workup. So we did the AD biomarker testing typically after we completed their workup, followed them for a while, and we're still not sure about their diagnosis. And in many cases, we did not expect that this biomarker testing would really affect treatment, management, or outcomes because there were not specific treatments for Alzheimer's disease. But for various reasons, we thought that greater diagnostic certainty would be helpful. So now things are very different because of this new AD-specific treatment that is available. In our clinic now, the most common reason that we're doing AD biomarker testing is confirmation of amyloid status in patients who are being considered for treatment with lecanemab. And we are doing this testing now in a much larger proportion of our patients, not just patients where we're not sure what's going on with them, but patients where we have pretty high diagnostic certainty of Alzheimer's disease, but we need confirmation before we can go further with considering treatment. We are also doing biomarker testing earlier, and this is because we know that treatments are going to be most effective when they are provided earlier in the disease course. We now have an expectation that this testing will have impact on treatment, management, and hopefully outcomes. So these factors are really spurring us to do much greater volumes of biomarker testing. We're doing at least 5 times the volume of biomarker testing that we were doing a year or two ago. So I'm going to go through the clinically available Alzheimer's disease tests that we use. These include amyloid PET, CSF biomarkers, and blood tests. So amyloid PET is very well established in research, clinical trials, and even in clinical practice. There are several FDA-approved tracers. Patients tolerate amyloid PET scans well, and there are few contraindications. However, we have rarely performed amyloid PET scans in clinical practice outside of trials because they are expensive. They cost about $6,000 at our center, and they had not been reimbursed by insurance until just recently. Medicare is now covering the costs of amyloid PET scans, but there are co-pays, and we are often uncertain about the out-of-pocket costs for individual patients. So that's really reduced our interest in ordering these. These amyloid PET scans are specialized. They have limited availability. The scans do require a small amount of radiation exposure, which is safe, but some patients don't like this aspect of the test. Patients have to lay flat for about 45 minutes for the scan, which is occasionally an issue. There is a perception that amyloid PET is perfect. However, the clinically used measure for amyloid PET is not perfect. It's a dichotomous read of the scan as either positive or negative. And a recent study showed that visual reads only correspond to the more rigorous quantitative reads in about 86% of patients. So there actually is a significant rate of inaccuracy of the clinically used amyloid PET scan. An additional disadvantage of amyloid PET is when you do a scan, it only tells you whether someone has amyloid plaques or not, and you can't use the scan to evaluate for any other conditions, which you can do with some other modalities such as cerebral spinal fluid. In our memory clinic, most of our AD biomarker testing has been with CSF tests, and this is largely for practical reasons that insurance has typically typically reimbursed most of the costs. There are currently 3 FDA-approved tests that have high agreement with amyloid PET. The CSF tests agree with amyloid PET about 90% of the time. Another advantage of CSF biomarkers is that you can use a single sample of CSF to evaluate for multiple conditions. So you can do other labs besides just Alzheimer's disease biomarker testing, and this is particularly helpful in cases where there's a complex differential diagnosis. For the Alzheimer's disease tests, they provide you with continuous values for multiple analytes, and this is helpful because you can get a sense for whether the result was a clear positive, a clear negative, or borderline. That's different than with amyloid PET, where you typically get just a positive or negative result. However, there are drawbacks to CSF tests. The major drawback is that most patients have never had a lumbar puncture, and many of them perceive lumbar puncture as invasive or risky. We are usually able to reassure patients, but this perception can be a significant barrier for some people. There are also some contraindications to LP, such as being on anticoagulation. The risks of LP are low, but some patients do experience a post-LP headache or back soreness. Another issue is that it's sometimes difficult to find providers to do LPs, and insurance doesn't adequately reimburse for LP. So in our clinic, we lose money on every LP that we perform, which is really not sustainable for many clinical practices. Now, while most patients have never undergone a lumbar puncture, all of them have undergone blood collection. Blood tests are very well accepted by patients, and they can be performed in patients who are on blood thinners. Blood can be drawn almost anywhere. You don't need specialized and expensive equipment like a PET scanner or highly trained personnel like you do to perform a lumbar puncture. This favorable acceptability and accessibility profile may enable the kind of scale that we really need to be able to address a common condition like Alzheimer's disease, which might require hundreds of thousands or even millions of tests to be performed yearly. That's the kind of scale that we really couldn't do with lumbar punctures or amyloid PET scans, I don't think. There are a number of blood tests that are now clinically available, but these have widely variable accuracy. Some blood tests are as accurate as FDA-approved CSF tests, as I'll show you, but some tests aren't really any better than a flip of a coin. So providers really have to do some of their own research before ordering an Alzheimer's disease blood test. All of the currently available Alzheimer's disease blood tests are what is referred to as laboratory developed tests. And what that means is they only have to meet basic standards to be offered to patients. None of these tests are yet FDA approved. And insurance typically does not pay for these blood tests. Sometimes they do, sometimes they don't. Private insurance typically will not accept a positive result on a blood test as adequate evidence of amyloid positivity for purposes of starting Alzheimer's disease specific treatments. However, in our clinic at WashU, we found that Medicare will authorize treatment with lecanemab based only on a positive blood test result. So there's a lot of changes going on and evolution in what insurers are paying, and we're not sure how things will change, but at least right now Medicare is reimbursing for lecanemab based on these tests. So given these new Alzheimer's disease treatments, they have really increased the demand for AD biomarker testing and driven this huge proliferation of Alzheimer's disease blood tests. This is a table of 16 of these blood tests from a review paper that was published 1 year ago. There are now many more tests that are being developed or offered. And as I mentioned, there is major variability in the accuracy of these tests, and the regulation of these blood tests is continuing to evolve. So how do we even evaluate the accuracy of these blood tests? So most validation studies, whether for CSF or blood, have used amyloid PET status as the reference or gold standard. So we separate individuals into PET positive and PET negative, and then apply a cutoff to the values for the blood test and dichotomize them as either positive results or negative results. And this allows us to calculate the sensitivity and the specificity of the test. You can see that for this particular blood test, which I'm going to describe a little bit more later, we're able to separate the amyloid PET positive from the amyloid PET negative individuals really quite well, the sensitivity of 91% and the specificity of 96%. Now, we often use a metric called the ROC-AUC, and this is a measure of the ability of the CSF or blood test to classify individuals as amyloid PET positive or negative. And 1.00 refers to a perfect test, and 0.50 is chance agreement or flip of a coin. Now, this particular test has an AUC of 0.973, so almost perfect. In clinical practice, the interpretation of this test result also depends on the pre-test probability or prevalence of amyloid positivity in the population being tested. Key factors that influence that include the age of the person being tested and their symptoms. So let's assume that in our clinical population that 61% of our patients are amyloid positive by PET. And I picked that number because that's the percent of patients that were amyloid positive by PET in the IDEA study. Now, all of these blood tests will get us closer to our goal of determining whether a patient has Alzheimer's disease brain pathology. However, while all these tests have a similar goal and work to some degree, the performance of these tests is not the same. So an analogy is some are race cars, some are station wagons, and some are bikes. Now, if you have an excellent test, you have a race car test with an AUC of 0.95, that's about a sensitivity of 90%, specificity of 90%. You would still expect about 10% of patients would have a discordant result of the blood test with their amyloid PET status. Notably, some research on these discordant cases has suggested that these individuals often have borderline levels of pathology. So this is still misclassifying 1 in 10 patients. I'll have to think about whether that's acceptable. But something that's more concerning is that many of the blood tests that are being used right now in research and even clinical care are not race cars. They're these station wagons or bikes. They may be good for some things, but I'm not sure that this is necessarily what you want to use clinically. So with blood tests with this AUC sensitivity and specificity of about 77%, you would misclassify about 1 in 4 of your patients. With this type of test, you would misclassify about 1 in 3 of your patients. Clearly, that would not be acceptable, that level of misdiagnosis. So how much discordance is acceptable in clinical care? Well, it's helpful to look at what has previously been approved. So here is information from the FDA applications for the 3 FDA-approved CSF tests. I'm not going to go through all these numbers on the slides, but the tests that were FDA approved based on data from less than 1,000 cognitively impaired research participants agreed with amyloid PET status in about 90% of individuals. They had an AUC with amyloid PET status of about 0.95. So they were race cars in terms of their level of performance. So this is helpful in that it gives something to shoot for with these blood tests. So how do these blood tests perform? Here is some data on a variety of blood tests. On the left is a meta-analysis of many different studies. So these are not head-to-head comparisons. These are individual studies looking at plasma A-beta 42 to 40. And you can see that most of these tests have a station wagon or a bike level of performance. And to get to the race car, you need something called p-tau 217, tau phosphorylated at position 217. And this percent p-tau 217 test developed at Washington University by Nico Bartolomei and the laboratory of Dr. Randall Bateman had the highest performance in classifying amyloid status in this head-to-head study. Now this may be confusing because many people think of A-beta as being representative of amyloid plaques and p-tau as representing neurofibrillary tangles. However, we have learned from a variety of CSF and blood test studies that p-tau 217 is an exceptionally good marker, not only of tau pathology, but also of amyloid pathology. And all the best blood tests for amyloid pathology measure plasma p-tau 217. Now, in this recent study that we just published last month in Nature Medicine, came from BioFinder and Washington University, blood and CSF was collected from research participants at the same time. And plasma percent p-tau 217 was measured with this test developed at Washington University. And the results were compared to CSF tests. These are FDA-approved CSF tests on CSF samples collected at the same time as a blood test. So this is really a very direct comparison of how well this blood test is doing compared to CSF tests. And what we see is that in our cognitively impaired individuals, there are 304 of them, that the tests performed the same, that they weren't statistically different in their classification of amyloid status. Blood tests performed just as well as a CSF test. We found the same thing in cognitively unimpaired individuals. Now, this test was licensed to C2N Diagnostics, which turned this assay into a clinical test. And last week, they just published a validation study in Alzheimer's and dementia. And note that all 583 individuals in the study were cognitively impaired. I will talk later about why that's important. But they found that this modeled value called the amyloid probability score 2 or APS2 had a AUC of about 0.94 in classification of amyloid status. I would just note that APS2 is a modeled value that takes into account both plasma A-beta 42 to 40 and percent p-tau 217. Now, there are additional studies validating this Precivityaddy2 test that have been submitted and are currently under review. Now, this metric, the amyloid probability score 2, I think is helpful clinically. And this is because when I return 80 biomarker results to patients, the first thing they want to know is whether they're positive or negative for Alzheimer's disease. But then as soon as I tell them you're positive or negative, the next question is, how sure am I? How sure are you that I'm positive? How sure are you that I'm negative? And with tests like amyloid PET, where they only give you a positive or negative result, I can't really answer that second question very well. However, with CSF tests and blood tests that provide these continuous measures, I have a much better idea of the certainty of the result. And this recent paper that was just published in Alzheimer's and Dementia looked at the positive predictive value and the negative predictive value associated with different APS2 values. And what you can see is that if you have a high APS2 score, that you really have very high of being amyloid PET positive. And in the same way, if you have a very low APS2 score, you can be pretty sure that the person is amyloid PET negative. And I find this particularly reassuring because when we're doing testing in patients where we have a pretty high pretest probability of amyloid positivity, if they have a positive APS2 result, particularly if it's in this high range, we have extremely high confidence that they are in fact amyloid PET positive. So this combination of the continuous value along with considering someone's pretest probability can really help you feel a lot more confident in a test result. Another issue that the field has been concerned about with regard to biomarkers generally and Alzheimer's disease blood tests in particular is whether they will perform consistently in patients who represent a variety of racial and ethnic groups and who may have a variety of different medical conditions. So in a biracial cohort from the NIGHT ADRC, we found that APS2 performs accurately and consistently in classifying amyloid status and was not affected by race, sex, hypertension, diabetes, or BMI. We need to do even larger studies, but these initial results do provide some reassurance that these blood tests may work in a general population. There are several other blood tests that are now clinically available or expected to become available soon. This study of the ALZpath plasma p-tau217 test classified amyloid status with AUCs of 0.3, 0.92, and 0.96 in 3 different cohorts. However, I would note that they studied mixed cohorts of cognitively impaired and cognitively unimpaired individuals. Unfortunately, the accuracy of the test in only the cognitively impaired individuals was not reported, and it could be somewhat different. It's probably not a lot different, but it could be a little different. This is an important issue because in clinical practice, we only perform 80 biomarker tests in cognitively impaired individuals. So we need to know how the test does in cognitively impaired individuals. Here's a recent study comparing the ALZpath p-tau217 test and the Janssen p-tau217 plus test. The main analyses were, again, in a mixed cohort of cognitively impaired and cognitively unimpaired individuals, where both tests had an AUC of 0.92 for amyloid status. However, they did do an analysis where they just evaluated the cognitively impaired individuals. And in that group, the AUC dropped slightly to 0.89 for the ALZpath test and 0.88 for the Janssen test. So as more of these Alzheimer's disease blood tests become available, and they more seem to be coming available every month or two, and as they're marketed to clinicians, it's going to be important for clinicians to examine the level of validation for these tests. There's some considerations for you to think about as you read these papers. So first, the studies really should evaluate cognitively impaired patients. That's who we're using these tests on. They should test pre-specified and clinically relevant cut points. They should consider negative and positive predictive values in clinically populations. And ideally, these studies should examine diverse groups, and that's diversity in terms of race, ethnicity, education, medical conditions, location, other factors. Also, I think it's important to note that you can't just compare test AUCs from one study to another. To really compare the accuracy of tests, you have to do a large head-to-head study. And I think that that's really what's needed to know which test is performing best. You can't just do that from different types of studies. So in conclusion, accurate diagnosis of Alzheimer's disease requires biomarker testing. And it's even more important now that disease-modifying treatments are available to do this testing and achieve an accurate diagnosis. While CSF biomarkers and amyloid PET have been widely used in research and clinical they have some drawbacks that limit their use in clinical care. Because of reasons related to acceptability, accessibility, and scalability, I think it's just a matter of time before blood tests become the major modality for AD biomarker testing. There are now a variety of AD blood tests available, and they have widely varying levels of accuracy, which is something very important for clinicians to understand. And some of these clinically available blood tests do have accuracy comparable to FDA-approved CSF tests with high negative and positive predictive values. I think that these AD blood tests are critically needed tools that will enable clinicians to provide an accurate diagnosis to more patients and help these patients to access these new AD-specific treatments, help them. So I find this very exciting, as I think these improved diagnostics and treatments are really going to help patients and their families to fight back against Alzheimer's disease, which is just a devastating disease. So I would like to express my gratitude to our research participants and their supportive families who have enabled all the work that I described to you today. I'd also like to thank my mentors and collaborators at WashU and BioFinder. And at this point, I'd be happy to take any questions.
Dr. Schindler, thank you so much. I'm so happy that we've recorded this because I'm going to have to listen to it over and over again. I particularly loved your analogy of the race car. Having started my career in Detroit, auto capital, I love that analogy. If you wouldn't mind just talking a little bit more about how you're using the blood biomarkers. I attended the ADPD meeting and I was amazed to see the BioFinder study report out. And I know that the primary care physicians weren't that accurate, but I also found it fascinating that neurologists only got it right about 70% of the time without the blood biomarker.
Yeah, no, I think biomarker tests are kind of humbling. I think that's generally true of a lot of diagnostic tests. I think neurologists always used to be correct about localization of neurological deficits until we had MRI, and then we found out that we were wrong sometimes. But yes, even when we do a very comprehensive workup and we have relatively high certainty that it's positive or negative, sometimes we're surprised. I've been surprised sometimes that someone I was convinced had, Alzheimer's disease didn't, or vice versa. So I think it's really because symptoms are related to real estate in the brain, and there's lots of different pathologies that can affect the same real estate. And so it's, we have to have these biomarker tests to tell us the answer. And they're even more important now that the treatments that we're using are really about that pathology. But in terms of, using this to improve diagnosis, yes, I think especially in situations where you may not have the same capabilities to do really thorough evaluation, that biomarker tests may be very helpful. So like a primary care setting, obviously I know that people are doing a lot of work on this to understand the most appropriate way to use them. But I do think that they can be quite helpful in enabling a more accurate, more timely diagnoses when used properly.
I also saw that, you broke the different analytes down, and it seems as if, different analytes seem to contribute differently. And, so that's why, when you were looking at the various tests, I think that you pointed out that there are some reasons to include the percentage p-tau. And you mentioned comorbidities. So can you just elaborate on that a bit, please?
So we have generally found that ratios can be quite helpful in normalizing for variation from person to person that's not actually related to Alzheimer's disease. So some people just seem to have more stuff in their CSF or plasma, and normalizing to total tau, as in the case with this percent p-tau ratio, or with A beta, using the 42/40 ratio, it really does seem to help quite a bit. And Oscar Hansen's group did a study that was published in JAMA Neurology showing that this percent p-tau 217 actually was much less affected by kidney function than just the raw concentration of p-tau 217. So I think that people sometimes don't like ratios for a variety of reasons, but they really can help us in normalizing for differences between individuals that are not related to Alzheimer's.
So I want to apologize ahead of time to people who are asking a lot of questions. I'm doing my best to moderate this because there's a lot of excitement and a lot of questions coming in. I'm going to try and pare them down so that maybe things are being asked, in a different way. So, are these blood biomarkers, in your opinion, ready for prime time? And if, looking at the Meyer paper and the clinical validation, do you think that for people who don't have accessibility to CSF and PET, would they be able to replace that in terms of at least the screening, or for looking at amyloid pathology for disease-modifying therapy?
Yeah, boy, that's a lot of different questions. So I think that if the question is just is someone amyloid positive or not, if you do one of these tests and you have a clear positive or clear negative result, like, as I was showing with the really high or really low APS2 scores, I don't think that doing CSF or amyloid PET is going to really help. You already have a pretty clear answer. I think if you have intermediate values, that's where I would consider doing a follow-up test. And that's actually where in our group we are doing follow-up tests, is when people have intermediate values. So are they ready for prime time? Yes, we're using them. I think that, again, it's helpful to have this continuous value and pretest probability. It does require some expertise to understand how to use these appropriately. I do think that, more for reasons of practicality than anything else, that these are going to have to get to primary care, or else there's just going to be many patients who never get a diagnosis, or who are misdiagnosed. Patients who would benefit from treatments who don't have access to them. So we need to figure out how to do this appropriately, but I think that this is going to have to get to primary care. And I'd also say that I have some patients that are coming to me with blood test results that their primary care docs ordered. So this is already happening. This is not a theoretical thing at this point. I would also say that I still think that different modalities are appropriate situation. For example, if I have a patient who has rapidly progressive dementia and I'm worried about an autoimmune mediated encephalopathy, I'm definitely going to do CSF. But again, if the question is just, are they amyloid positive or amyloid negative, I think that the blood tests are really quite good at answering that question.
Yeah, and just as a follow-up, then it becomes even more important that when we are looking across the different blood biomarkers, that we figure out, the whole aspect of indeterminate values, particularly if you're looking for a binary like positive predictive value and negative predictive value, that we look at tests and look at, how indeterminate values are going to be, accounted for. So I think that that's really, really important, because particularly if you're just screening and trying to streamline patient care and ascribe clinical pathways to really address the unmet need and the time toxicity and getting to disease modifying therapy, that we do the most accurate test for that reason. We're getting a lot of questions on insurance coverage, etc., which we can take offline, because that's really for us to follow up on. I am getting some questions on, how you're utilizing this test. Could it be used for asymptomatic or screening, or if patients have a high risk? And I wonder if you're doing that in the clinic, or you're getting those questions from patients in your practice.
Yeah, so at this point in time, I personally don't think it's appropriate to do biomarker testing in asymptomatic individuals outside of clinical trials and research studies. And the reason for that is there are potential drawbacks to having this information. Some patients who are cognitively unimpaired want this information because they want to know, and they think that it may affect their decision making. But at this point, we don't have a treatment to offer those individuals. So I personally have never done AD biomarker testing in cognitively unimpaired individuals, and most of my colleagues have not. Now, if we have a clinical trial that demonstrates that treatments are effective in slowing or preventing onset of symptoms in asymptomatic individuals, then that will all change. But that's not going to happen for, at least a couple of years. So in the meantime, we'll have some more time to see how these tests perform.
Getting some more questions on comorbidities, particularly, kidney disease. And I think you did mention, but maybe we just, for some of the clinicians on the call, just again, looking at differences between testing multiple analytes and the ratio that might clarify things, and the difference between the PrecivityAD test and the PrecivityAD2 test, if you don't mind going along that same vein of multiple analytes and the ratios.
So the PrecivityAD test uses A beta 42 to 40, age, and ApoE to provide a risk score for being amyloid positive. The PrecivityAD2 test uses A beta 42 to 40 and the percent p-tau217, again, provide a risk score. We know that so in the paper that was recently published by Meyer in Alzheimer's and dementia, it shows very clearly that the percent p-tau217 is the very accurate measure of amyloid status. And the combination of A beta 42 to 40 plus percent p-tau217 is more accurate than percent p-tau217 by itself. So that is what PrecivityAD2 is. It's that combination of the markers that have been shown to be most accurate. But yes, we think that I think that the 2 version and the data really shows that the PrecivityAD2 version is more accurate. In terms of the question about comorbidities and kidney disease, if someone was on dialysis or had really severe kidney disease, and I wanted to do biomarker testing on them, I would probably do amyloid PET if I could, or CSF testing, just because we don't have as much information on that population. Of course, we're not quite sure how amyloid PET CSF is going to do in that group, if that will perform exactly the same either. But at least the paper from Oscar Hansen's group in JAMA Neurology showed that people with less severe kidney disease, that the percent p-tau217 really performed really quite well. It was the concentration that was by itself that was strongly associated with kidney function.
I'm going to take the moderator's opportunity to close this out, because I think we'd keep you till midnight. There has been so much anticipation and excitement about this. So I'm going to hand things off to Corey. I want to thank you so much, Dr. Schindler. As a clinician, as a neurologist, I learned so much from you. And again, we have this opportunity to listen to this again. And thank you very much for your time and your presentation. Corey, I'm going to turn this back to you now.
Yes, thank you very much, Sheena, and thank you, Dr. Schindler, for your excellent presentation. As Sheena mentioned, at this point, we have reached the end of our Q&A session. We saw lots of questions coming in, so for those of you who we couldn't attend to your questions, to anyone who has any further questions, or to anyone who's watching the recording of this webinar and wants to get in touch with the team, I'm sharing an email address on now that you can send emails to, and use that contact info there, and they will have a chance to follow up with you after the webinar. I do thank everyone once again for participating in today's webinar. As we speak, I'm adding a link in the chat box here where you'll be able to share today's recorded webinar with your colleagues. You can share this link with them and they can register to view it as well. You will also be receiving a follow-up email from XTalks rather, that will provide access to today's recording. And as we wrap things up here today, please note that a survey window will appear on your screen. Your participation in the survey is always appreciated, as it does help us improve our webinars. And now, please join me once again in thanking Dr. Schindler once more for her excellent presentation. Sheena, thank you for moderating and for working the introduction and the Q&A. I thought it was an excellent webinar all around. I enjoyed myself. I know our audience did too, and I'm sure we all learned a lot. We hope you found this webinar informative, and we wish you all a great rest of your day. Take care, everyone.
Thank you.